what happened?
He will give the countdown, sir. After that, I'll give the intro. Then you can start the presentation, sir.
Okay.
Yeah. Tech team?
Yes, sir.
Yeah.
Okay, sir. Please start in 3, 2, 1.
Good evening, everyone. It's my pleasure to welcome you all for today's scientific meeting. We are honored to have Dr. Karthik Balaji, sir, medical oncologist from Miyot International Hospital, and yet another doctor also joined, Dr. Karthikeyan, sir, from medical oncologist from Miyot International Hospital. Dr. Balaji, sir, is presenting the topic in prostate cancer. So I don't want to delay further. I hand over the session to Doctor. Over to you, sir.
Thank you. Thank you for the kind introduction. So I will take forward from here. Hope the slides are visible.
It's perfect, sir.
Yeah, it's perfect. Okay. Very good evening, one and all. Thanks for joining today through this meeting. And so I'll be presenting today regarding the advancing treatment options in metastatic hormone-sensitive prostate cancer. So darolutamide with or without chemotherapy, that is aronate evidence. So we would have been already familiarized with the triple therapy with the Arasan evidence that is a combination of ADT plus darolutamide plus docetaxel in metastatic hormone sensitive prostate cancer, especially in the high volume settings. So today we will be dealing a specific group of patient where patient who are not fit for triplet therapy, that is chemotherapy, and who are only fit for doublet therapy. So what is the recent evidence and how darolutamide will help us in deciding patient factor, and is this a game changer in the metastatic hormone sensitive prostate cancer who are not eligible for chemotherapy based regimen? So with this quick introduction, so I'll be going through the subsequent stuff. Yeah, I think there is some problem. So this is the disclosure. So coming on to the standard of care evolution, especially in the metastatic hormone-sensitive prostate cancer. So it has evolved initially with the combination of ADT with AR inhibitor, that is abiraterone or docetaxel. So initially, the initial data comes from the charted Stampede trial and the Latitude, where a combination of ADT plus docetaxel or ADT plus abiraterone become the doublet therapy, become the standard of care till 2017. Following this, over the last decade, there has been incorporation of many agents apart from the abiraterone, enzalutamide with ADT also become one of the regimen or the treatment based upon the Archie's trial, and the Titan gave way to the tapalutamide and the ADT. And the Enzamet gave a combination of enzalutamide plus ADT plus or minus docetaxel. So the two game changer, it is one of the preferred regimen for fit patient based upon the Arasan trial, which is darolutamide plus ADT plus docetaxel, which is established as a standard of care. Whoever is fit for a triplet regimen, and alternate will be abiraterone plus ADT plus or minus docetaxel. So peace trial. So today we'll be discussing about the aronate trial, where darolutamide plus ADT will be discussed. So despite the treatment with the ARPI plus ADT or docetaxel plus ADT, large proportion of patients with metastatic hormone sensitive prostate cancer will progress to metastatic CRPC within 3 years. So what is the unmet need in therapeutic treatment of metastatic hormone sensitive patient? So there is an unmet need remain as an efficacy treatment that offer a differentiated and improved safety profile of patient with metastatic hormone sensitive prostate cancer without adding significant toxicity. So if you take other drug, especially the abiraterone plus ADT or apalutamide or enzalutamide, there is a significant side effect associated with that. So Arasan and is a phase 3 trial which studied the combination of darolutamide plus docetaxel, especially in the metastatic hormone sensitive setting. So this is the aronate trial, which will be evaluating darolutamide plus ADT in metastatic hormone sensitive prostate cancer. So darolutamide plus ADT with docetaxel is a standard of care in like metastatic hormone sensitive prostate cancer. In Arasan, darolutamide plus ADT plus docetaxel become the standard of care as already previously discussed. So Aronate trial was designed to evaluate whether doublet combination, that is the combination of darolutamide plus ADT versus ADT, provide a better standard of care compared to the ADT alone. So coming on to the trial design, so Aronate is a double-blind, placebo-controlled phase 3 study. So it is a double-blind. So both the participant and the researchers has been blinded which drug they are receiving, either like placebo or the darolutamide. Only the data analyst will be knowing which category of patient has been allotted the interventional group. So total 665 patients have been included. Mostly the patient were metastatic hormone sensitive prostate cancer. They should be histologically or cytologically confirmed adenocarcinoma of prostate, and the performance status should be 0 to 2. Stratification factor, whether the patient had visceral metastasis, because we obviously know that the patient with visceral metastasis have a poor prognosis compared to that of patient not harboring visceral metastasis. So prior local therapy was given or not. So depending upon that also the stratification was done. So it was a 2:1 randomization. So like darolutamide was the interventional arm where 600 mg was added additional to that of ADT. In the control arm where like placebo plus ADT was used. So the primary endpoint is radiologically progression-free survival, and the secondary endpoint include overall survival, time to initiation of subsequent anti-neoplastic therapy, time to CRPC, and time to PSA progression, and sustained remission. That is like a rate of undetectable PSA that is less than 0.2 nanogram per ml, time to pain progression, and safety. Other pre-specified endpoint has been listed. So once the interim analysis or the efficacy has been shown, the trial has been made into open label, because when a clear evidence of doublet over a single is established, most of the patient, even in the placebo, have been given a chance to cross over to the doublet arm, that is the open label, like addition of darolutamide. So the date of cutoff period was June 7, 2024, and median follow-up was 25.3 months in the darolutamide and 25 months in the placebo group. Coming on to the patient demographic and clinical characteristics. So like if you see between the interventional and the control arm, both the parameters have been well matched, and most of them were Asians. And then if you see like de novo metastasis contributed almost 70% of the population, and like high volume contributed almost around 70% in the both the arm. And the visceral metastasis, if you take, they are like seen only in like limited, that is 12% of the population. And prior local therapy was given only about 20% of population. So this is with regard to that of different trial and their enrollment. If you see like Aronate included much of Indian population also, that is Asian. So that what we have to be. So we when we are using in our patient also, this will be a better ethnic population represented very well in the Aronate trial. So again, repeat of the same thing. So Indian represented almost 14% in this trial. So coming on to the primary analysis, that is the primary endpoint. When darolutamide was added with the ADT, that led to like significant decrease in the rate of radiological progression. That is the hazard ratio of 0.54, which was statistically significant, which is translated into 46% decreased chance of death due to progression of the disease. So which was like significant. If you take other trial also, usually the hazard ratio will be somewhere from 0.5 to 0.7 across different combination of ADT plus ARPI or like triplet combination. So the result was well within that expected outcome, and it was like statistically also significant. So coming on to the subgroup analysis, so the benefit of adding darolutamide was seen irrespective of like subgroup. So across like patient who are elderly also and like baseline PSA value more than median, and like patient with higher Gleason score and high volume disease. So across like different population, ethnic, that is even Asian, had a better response with the addition of darolutamide. And like even patient with visceral metastasis was underrepresented, but still there is a response. So that is the reason the number of patients were less 12%. So that is the why the confidence interval is crossing the midline. So the prior local therapy also, like irrespective of the prior local therapy, all the patient are benefited. So overall, this forest plot shows that it is like the darolutamide favored over that single ADT alone. So coming on to the secondary endpoint, so OS and the time to metastatic castration resistant, or time to PSA progression, and time to initiation of subsequent therapy, or time to pain progression, which was like better when darolutamide was added to the ADT background compared to ADT alone. So all this secondary endpoint also favored the darolutamide. So during the primary analysis, OS data are immature. Since OS is immature, patient will be followed for survival. All the remaining per protocol patient offered crossover to darolutamide after primary analysis, like already said. So like after the primary analysis was done, patient were offered to shift over to the darolutamide. So coming on to darolutamide plus ADT, delayed the time to CRPC and time to pain progression also. So you can clearly see in this Kaplan-Meier chart that both the arms is being separated, and the darolutamide plus ADT, you can see it is flattened after 2 years, and time to pain progression also better when darolutamide was added to the ADT. So overall, delay in time to pain progression can be high importance to patient, and not have been demonstrated with AR inhibitor to date, other AR inhibitor to date. So pain control is one of the main problem which we will be encountering when patient comes to us, because mostly patient will have like multiple bone metastasis, and one of the tiring complaint which patient always say, like when he can get rid of the pain. So darolutamide shown typical like pain control, and time to pain progression also, the recurrent of the pain was also like prolonged. So that means that darolutamide give a sustained pain control over longer period compared to ADT alone. So when we compared with different other ARPI, darolutamide is the only drug which had shown like to have a better pain control. So darolutamide plus ADT achieved a deeper response. That is, the PSA value less than 0.2 nanogram was like during any treatment was 63% in darolutamide arm had a sustained PSA control, and it also like 69% improvement in time to PSA progression. So you can also see this Kaplan-Meier chart where that the darolutamide is still separating widely from that of ADT alone, and the line is almost flattening. So the hazard ratio is 0.31, which is like 69% reduction or improvement in time to PSA progression. So when you compare between both the arm, that is irrespective of the high volume or the low volume disease, when we compare a darolutamide plus ADT versus ADT alone, patient in the doublet arm, that is had a better like undetectable PSA compared to that of like singlet arm. So both, if you see a patient who like subsequently progress in both the arms, most of the patient have been subsequently treated with docetaxel chemotherapy, and other agent being abiraterone, enzalutamide, and apalutamide. So incidence of like adverse event, when we are comparing between the two arms, it is almost like any adverse event was like almost comparable. It is like 90% across both the arms, and grade 3 or grade 4 also was 30% across both the arms. So median treatment duration was slightly better, that is 24 months in darolutamide, because patient didn't develop any new usually when we added another drug to a treatment, we obviously expect an additional toxicity, but it was like almost comparable. The drug also given the patient sustained remission. So all these things made the patient to be on longer duration of like darolutamide. So that is the reason why median treatment duration was better in the darolutamide arm versus the placebo arm. So like the toxicity leading to permanent dirotomy discontinuation was lower than that of placebo. That is only 6%. So when we compare, the fatigue also was like slightly higher. If you take, we always know when we are adding AADT and ARPA, most of the we are like cutting down the testosterone. So that is the one of the reason why patient land up in fatigue. So when we are adding another agent, like especially like other ARPA, we expect higher level of fatigue. But the fatigue level was still slightly higher compared to that of ADT, but it was not very significant. And coming on to that of other this one, which was like comparable between the both the arms. So when we are taking like a health related quality of life, darolutamide confers a positive impact. That is, the pain control is excellent, and like patient overall well-being also is excellent. When we compare, there is a clear 5.1 months gap between the two arms. That is the darolutamide plus ADT versus placebo plus ADT. So these are the aspects where the darolutamide addition to that of ADT help. That is the social well-being, functional well-being, and urinary syndrome. So definitely, like apart from that of disease control, it also helps in the improvement of quality of life, which is like a better thing, because most of the problem we face when we are adding like ARPA to the ADT is like quality of life, because patient will end up in lot of side effect which will be difficult to manage, and leading to multiple treatment interruption, and leading to like decreased outcome. So like when a drug which is helping in like betterment of the quality of life, definitely it should be given a like preference over the other thing. So to summarize, like Chartered gave the idea of high versus low volume disease, and Latitude gave that high risk category, and the Stampede gave low volume low volume disease. When RT is added, then it will lead to OS benefit. And Abiatoron is like for both high volume and low volume based upon Stampede trial. And low volume doublet is preferred. That is enzalutamide, darolutamide, another. High volume chemo with doublet is preferred. Even in high volume, when the patient is not fit for chemotherapy, doublet treatment can be given. And based upon the RNA trial, darolutamide plus ADT is also like a preferred option when the patient with high volume not eligible for chemotherapy. And when a patient is high volume, always like triplet is preferred. We all know. So to conclude, darolutamide plus ADT significantly improved the radiological progression-free survival in patients with metastatic hormone-sensitive prostate cancer. Darolutamide showed a benefit across all secondary endpoints, and darolutamide was associated with the deep PSA response regardless of baseline PSA. And darolutamide is the only AR inhibitor to demonstrate clinical meaningful delay in the pain progression and overall well-being, like already we discussed, in the social and family well-being, functional well-being, and urinary symptom. So darolutamide had a favorable so apart from, so like when we usually choose a drug, apart from the like in especially in a metastatic setting, the thing which we'll be considering in choosing a drug is, the first is that outcome in the form of like either overall survival, progression free survival, or like disease free survival. When all the things are comparable, the second thing which we usually take is that of like quality of life or the side effect profile. So I think like darolutamide is excelled both in the tough outcome, that is the overall and the progression free survival, as well as the safety profile. So which we can see from the above RNA trial. So darolutamide plus ADT without docetaxel should become an additional standard of care for metastatic hormone sensitive prostate cancer, who are like not ineligible for chemotherapy, or like who are having low volume disease. Thank you. Hello.
Thank you, Doctor, and thank you very much for the insightful and informative presentation. We are truly appreciate your time, sir. Sir, actually, there are a couple of questions in the chat box, sir.
Okay, I'll just check it. Okay. Okay, fine. So that what? So the first question is like, after using darolutamide in metastatic hormone sensitive prostate cancer, what is your preferred treatment sequence once the patient developed MRCP? So usually we need to do a biopsy and repeat biopsy and need to do the NGS and the BRCA study. So that will be the preferred. So if the patient is still fit, we can in the trial, we can always use the docetaxel based chemotherapy. Otherwise, we can use based upon BRCA status, we can use targeted agent. So that will be my this one. So for subsequent line of treatment, obviously for all metastatic, even in the hormone sensitive prostate cancer now, doing the NGS and the germline HRD and the BRCA testing become the standard nowadays. So that is the thing. I hope that answered the Dr. Kishore question. Or hello. Hello.
Sir, can you hear me? Sir, one more question
Yeah.
there. How do you select between?
Yeah. I hope Dr. Kishore is satisfied. Or still he can post it, I guess.
Yeah.
Okay. The second question is okay. It's a very good question. So, how we that what initially when we are choosing a patient, that what so all the three drugs have a comparable outcome. So, when we are choosing, obviously we will be taking into the side effect profile. So, patient who has previous history of seizure and so in that patient, we will try to avoid enzalutamide because obviously enzalutamide having a CNS, it can cross blood-brain barrier. So in those patients, we will try to avoid enzalutamide. And abiraterone, we will be patient who are already having. So abiraterone who are already having cardiac comorbidity, uncontrolled hypertension, and then patient who are having electrolyte abnormality. So those patients we will be trying to avoid abiraterone. So darolutamide is kind of very safe apart from that of fatigue. So even patient with high pre-existing cardiac condition or epilepsy or seizure history. So darolutamide, if patient is having multiple comorbidity and multiple problem, definitely darolutamide should be preferred. So that is how so it is a case to case selection. So we might take into the previous patient details also, comorbidity and tolerance. So everything, and the cost factor also, definitely cost.
Okay.
So the cost, everything plays an important role. So it is a combined decision between the physician and the patient. So we will be helping the patient in taking a decision which will be better. So all the criteria should be taken into account.
Thank you, sir. Thank you very much. Dr. Karthikeyan sir is yet to join, sir. He will be joining in a moment, sir.
Okay. Any other question?
I think that's all.
I think I missed one thing, which I think first question I missed. Which efficacy endpoint mattered the most in your day-to-day practice? Overall survival, radiological problem. So this is an interesting question. So when we are taking by cancer, so definitely cancer with prolonged survival. If you take breast cancer, prostate cancer, where the survival is in years. So definitely there we need to have a progression-free survival. We obviously know progression-free survival will be translated into overall survival. So when a cancer which is having a very short span, 6 months, pancreatic cancer or a very aggressive tumor. So in that case, we will be preferring overall survival over the progression-free survival. So in case of breast and prostate, it is very difficult to establish an overall survival where we need several years, 5, 7, 10 years follow-up to show a difference in the overall survival. And we have a second line and third line option. So in that setting, to show overall survival will be confounded by the subsequent treatment and the patient profile, everything. So in that case, where the cancer is having an excellent survival, there obviously progression-free survival will play an important role. And coming on to that of so when a patient is having longer survival, so we don't want the patient to deteriorate in the first line itself. So the drug which provide a better progression-free survival and maintain the quality of life, so that when the patient progress, the quality of the life of the patient is managed, so that we can go aggressively during the second line. So that is the thing. If you take like most of the cancer, where it is aggressive biology or most of the cancer, almost 10 to 20% of the patient when they are progressing will have like deterioration in quality of life suddenly, so that they won't be eligible for any like standard of care. So either like sub therapeutic treatment or like best supportive care is offered. So when a line which is like first line, when an agent is offering both the better PFS and quality of life, I guess we should be choosing that, so that the patient will have like better chance of getting a standard of care in the subsequent line. I guess that answered the first.
Thank you, sir. Thank you,
Sorry.
sir. And
Yeah.
one more thing, sir, you have the experience of using darolutamide already your patient. So if you can,
Yeah.
please share your personal experience with
Yeah.
darolutamide.
So my patient was like a 60-year male who was having like lower urinary tract symptom for past 2 years, but especially hematuria and increased frequency. So patient was completely ignorant, but after 2 years, when he had some chest pain and dizziness, he was evaluated at his local hospital, where he was found to have like aortic aneurysm, not typically dissecting, but aortic aneurysm, not requiring immediate surgical correction. So the patient came to us. So during the evaluation for the chest problem, CT scan revealed multiple like bony meds. So he revealed to the treating physician the patient was having some urinary symptoms. So he was referred to us. When we evaluated, he was found to have like adenocarcinoma of prostate with Gleason score of 9 and a PSA more than 100 and multiple bone high volume disease. So when we were discussing in our tumor board, the cardiothoracic surgeon of the opinion, they want the primary cancer to be controlled before proceeding, because the cutoff was not met, because the cutoff was 5.5 centimeter. He was having 4.5 centimeter. So we initially proceeded with that of ADT and darolutamide. So after 15 days, the PSA dropped to less than 20, that is 18, and the patient was almost like bedridden. The power was 0. So patient slowly started, within 2 weeks, started to have like power rose up to 4/5 in both the lower limbs. And after 1 month, we actually waiting for the cardiac status to improve, and then the tolerance of the darolutamide also. So we didn't immediately expose him to the docetaxel. Instead, we integrated PSMA therapy, because after a month after darolutamide and ADT alone, he almost had 60% of cancer control. So, but the pelvic bone was showing like a PSMA uptake. So, the nuclear medicine was brought into the picture, where the patient received 1 doses of PSMA therapy. The thing is that no, when I gave the darolutamide for the first time, like a patient developed a TLS, because the disease rapidly melted, and clinically also patient started to improve. It was one of the thing which was even though like an oncology, it was a double-edged sword. Managing a TLS is problematic, but once we manage, we can see the patient improvement also drastically. He improved so much. So finally, now the patient is on concurrent triplet therapy, that is docetaxel has been given 2 cycle, and he is doing well. Now he is walking, he is very happy, and no side effect of darolutamide till now. No fatigue, no weakness, or no tiredness. So still the patient is on triplet therapy, and the PSA is less than 0.2, it is shown in the trial. So he's doing well now.
Thank you, sir. Thank you very much for sharing your experience on darolutamide. Dr. Karthikeyan sir is joined. I welcome Dr. Karthikeyan sir for this virtual scientific meeting. Doctor is presenting today newer heights in MHSPC care. So, Doctor, without further delay, please start your presentation, sir. Over to you, sir. Karthikeyan sir, can you hear me, sir? Yes.
Sir, am I audible, sir?
Yes, sir. No, it's audible.
My slide is visible?
Yes, sir. Visible, sir.
Good evening, everyone. I thank Bayer for the opportunity. Um, I will now be discussing on the um, management of metastatic hormone-sensitive prostate cancer and the evolution of treatment and where we can place a darolutamide in the place of the current management. So if you look at the prostate cancer landscape, the prostate cancer, whether it is localized or locally advanced, once we complete the definitive local treatment, it can be either radiation treatment or surgical treatment. The recurrence usually starts as a biochemical recurrence. When there is biochemical recurrence, then it would be labeled as a hormone sensitive prostate cancer recurrence. Following biochemical recurrence, once the patient is started on treatment for the hormone sensitive disease with on androgen deprivation therapy, any further progression would be labeled as metastatic castrate resistant prostate cancer. Now, why we fear about delaying the occurrence of castrate resistance is once the castrate resistant phase is reached, the median overall survival is in the range of 6 months. So that is why it is always better to prolong the castrate sensitive phase. I mean, that is the castrate sensitive hormone sensitive phase. That is. So we should delay the onset of CRPC because the outcomes once that happens is the prognosis is poor. If you look at the Stampede trial, it was the randomized trial which compared addition of docetaxel to the previous standard, that was androgen deprivation therapy in metastatic hormone sensitive prostate cancer, famous trial from the UK group. By the addition of docetaxel, there has been an improvement in the overall survival and also the free survival. And from the Stampede data, the patients are divided into high volume and low volume disease. High volume disease is defined as presence of more than four bone metastasis or any visceral metastasis or any metastasis outside the true pelvis. Low volume disease is defined as less than four bone metastasis. And if you see the addition of docetaxel has improved the outcomes in the low volume disease. Sorry, in the high volume disease. But if you look at the addition of local radiotherapy, that is, we have seen here how to improve on these outcomes. So we thought whether addition of local radiotherapy to the prostate can, whether that might improve the outcomes. So if you look at the outcomes in patients who have less disease burden, in them treating the local prostate organ with radiotherapy is found to improve the failure-free survival and also the overall survival. The hazard ratio is 0.56 for the failure-free survival. And for the overall survival, it is 0.64, which is statistically significant. Whereas in the subgroup of patients with more than four bone metastasis, the difference between addition of radiotherapy or only systemic treatment, the difference was not pronounced. So one, we thought whether addition of local radiotherapy can improve. That has improved in the low volume disease. What about the trying to improve outcomes with intensification of the systemic treatment? That was the Stampede, one of the arms, that is the Stampede trial, the Charter trial, the J2 trial, which all tried with incorporation of chemotherapy, that was docetaxel to the pre-existing standard. Then we have the subsequent Archie's trial, the Titan trial, the Enzyme trial. These were with looking at evidence of addition of abiraterone to the standard. That is, the standard is androgen deprivation therapy, docetaxel plus androgen deprivation therapy. The other new addition was androgen, that is abiraterone acetate, then addition of enzalutamide. These are the various studies. Across all the studies, the hazard ratios are in the range of 0.6 to 0.7, which are statistically significant for overall survival. This past decade and a half has led to this improvement. Otherwise, the treatment prior to 2013 or 2012 was only androgen deprivation therapy and chemotherapy and other agents. The evidence started from the CRPC setting. So if you look at the charted trial, which looked at docetaxel and hormone-sensitive prostate cancer, it was stratified into low volume disease and high volume disease. Patients with high volume disease who received docetaxel, they found to do better compared to the low volume disease. This is in contrary to the addition of radiotherapy in the low volume disease, which showed benefit in the one of these STAMPEDE trials. And it provided a median improvement in the OS of around 16 months compared to the androgen deprivation therapy alone. That is, patients with ADT and docetaxel, their median overall survival was 51 months versus 34 months. And in the low volume disease, they did even better. The median overall survival was 63 months versus in androgen deprivation therapy, it was not reached. Then, if you look at abiraterone as addition, the median follow-up of 51 months between the two groups, it was the first to show that hormonal treatment can be effective. However, if you look at the treatment journey of the patients who are in the placebo arm, they subsequently went on to receive androgen deprivation therapy and that might explain why the overall survival benefit was not there. The use of abiraterone in hormone-sensitive prostate cancer, it is to be combined with the addition of prednisolone. This is to prevent the mineralocorticoid excess and the symptoms related to that is hypertension, hyponatremia, and hypokalemia, and so on. If you look at the combination of abiraterone and androgen deprivation therapy with the prednisolone, the grade 3 toxicity was seen in 22% patients, whereas with placebo it was 10%. And following crossover to abiraterone, the grade 3 toxicity was 4%. LFT improvement was in 5% in grade 3. Hypokalemia is the next most common after hypertension, that happened in 11% patients, whereas 1% in the placebo arm. So the Titan trial evaluated the role of apalutamide in metastatic hormone-sensitive prostate cancer. It was a combination of apalutamide with androgen deprivation therapy. The progression-free survival and overall survival, in both there was an improvement, statistically significant. The PFS had an hazard ratio of 0.48. The OS hazard ratio was 0.65. And in this trial, in the docetaxel trial, the high volume disease benefited, whereas in the apalutamide trial, the low volume disease benefited for the progression-free survival compared to the high volume. Both the groups benefited, but the low volume derived more benefit. Coming on to the enzalutamide trial, that is the Enzamet, the hazard ratio again is more or less similar, around 0.4 to 0.5 for the progression-free survival, and for the overall survival, it is always hovering around 0.6 to 0.7. And here again, if you look at the low volume disease, they derive more benefit compared to the high volume disease. So what about combining both these androgen pathway inhibitors to the chemotherapy? First came the PEACE-1 study. This included de novo metastatic hormone-sensitive prostate cancer. It excluded the recurrent disease and the patients who have received prior chemotherapy. Here again, the disease was stratified into low volume or high volume disease. The treatment arms was standard of care, that was androgen deprivation therapy followed by chemotherapy. The standard of care was androgen deprivation therapy earlier on in the study. Then following the publication of the STAMPEDE trial and the CHARTED trial, then the androgen deprivation therapy plus docetaxel became the standard of care. So subsequently, later on in the same trial, the subsequent standard became ADT plus docetaxel. In addition to it, they evaluated the role of abiraterone acetate. Here again, if you look at the high volume disease or the low volume disease, whenever you add chemotherapy, it is the high volume disease that benefits the most. The median progression-free survival is around 5 years in the abiraterone group versus it is 3.5 years in the standard of care group. Whereas if you look at the low volume disease, the difference is not much, it is statistically not significant, the difference. So this led to a confirmation that in high volume disease, you can improve the results by adding abiraterone to the docetaxel versus docetaxel alone. Whereas if you look at the androgen pathway inhibitors, they work better in the low volume disease. So we are combining the both to achieve improve on the previous improvements. The Arasen study is a phase 3 study. This used the randomized study between docetaxel alone or addition of darolutamide versus placebo. In addition to androgen deprivation therapy, it was a 1:1 randomized study in 1,300 patients, and this study happened between 2016 to 2018. The primary endpoint of the study was the overall survival. Secondary endpoint was time to castrate-resistant prostate cancer, time to pain progression, and skeletal metastasis symptom event-free survival, and the time to first symptomatic skeletal event, time to initiation of subsequent anti-neoplastic therapy, and time to worsening of the physical symptoms, time to initiation of opioid use for beyond 7 days. And if you look at this data, more than 85% of the patients received all 6 cycles of docetaxel. So which it is indicating that the patients went on to were fit enough, even though it was a disease of the older age group, they were still fit to receive systemic treatment. If you look at the overall population, for the placebo group, the median survival was 48 months, whereas the median is not reached in the darolutamide arm. And if you look at the event at 51 months, 63% of the patients are still alive at the end of 4 years, whereas 50% in the control group. So we if you look at the initial studies, that is the docetaxel studies, the median progression-free survival was around 45 months, whereas now here it is not reached, and 60% are still alive at the end of 4.5 years. And unlike the other agents, this benefit is seen in all the subgroups, whether it was high-risk patients or the low-risk patients. And time to CRPC, that is, we always want to delay the onset of CRPC. There is a 64% risk reduction in delaying the onset of CRPC. And time to first subsequent anti-neoplastic therapy, again, everywhere that is risk reduction is around 60%, whereas to pain progression, there is a 21% risk reduction. And first skeletal event, symptomatic skeletal event progression, there was again a 30% reduction. At 6 weeks, that is at 6 months, 50% of the patients have gone on to reach undetectable PSA levels, whereas by the end of 1 year, 60% of them, more than double of the patients in the placebo group, go on to become go on to reach undetectable PSA levels, which is very important marker of response. At any point, close to more than 2/3 of the patients have achieved PSA level below 0.2. And the time to PSA progression, that is time to reaching undetectable PSA levels at 36 weeks, it was not reached, the median is not reached, whereas in both as placebo and in the dorlotamide group, the median is not reached, but the hazard ratio is very impressive, 0.23, that is 87%, 77% risk reduction in the risk of progression to progression in the PSA. And the overall survival, the median is not reached, but if you look at the 51-month survival, there was a 60 versus 47%, 63 versus 50% this thing. And the hazard ratio compared to what we have seen, always we have seen an hazard ratio of 0.6 for the other studies, whereas the hazard ratio for overall survival is the maximum here. The hazard ratio is 0.37, that is, there is a 63% risk of reduction. If you look at again the PSA response study, we have already seen the undetectable PSA patients achieving undetectable PSA at 24 weeks was around 40%. At the end of 1 year, it was around 60%. So the triplet achieved longer periods of no disease progression and also significant improvements in the overall survival. If you look at the time to PSA progression, that again the median time to PSA progression was not reached and the hazard ratio was 0.2. The overall survival, again we have seen this, the hazard ratio is 0.3. Whereas if you look at the other studies, points for overall survival, the hazard is usually around 0.6. If you look at the PSA response in the low volume disease, it is working both in the low volume disease and in the high volume disease. Although the margin is, if you look at the width between the curves, that is more pronounced in the high volume disease, whereas it is working even in the low volume disease. The hazard ratio continues to be 0.3 versus 0.34, whether it is high volume disease or low volume disease. So how to decide between a doublet and triplet? We have to definitely look at the patient fitness. The cost factor also needs to be considered, and the patient needs to be fit enough to tolerate. And this has a good and favorable. This being a newer generation androgen pathway inhibitor, so this has a better tolerance profile compared to the first generation, the early generation, that is enzalutamide. And patients should be fit for systemic treatment. The docetaxel is going to be the more toxic of all the agents, relatively if you compare. So that a patient has to be fit enough for systemic treatment. And patients, whether they high volume or low volume, if you look at the volume status, the high volume disease seems to benefit from the triplet therapy, seems to benefit from the addition of chemotherapy. But when it comes to only uh, androgen pathway inhibitors alone, then the low volume disease seems to derive more benefit. And patient has to have a good life expectancy. Basically, they have to be fit for the treatment. And it may so happen that that if you hit hard and if you hit early, then prostate cancer may not become the cause of death. The patient may live long enough to survive the prostate cancer and may die of other age-related or natural causes. And docetaxel, will it be an obligation? Yes, all the trials are incorporating docetaxel, so that has become the basic backbone. We have looked at addition of oral medications to it, and that has improved the outcomes. But how much less effective post ARPA progression? Now that we are including all of these in the front line, for post ARPA progression, we are having limited medicines. We are one available option could be the PSMA therapy, and we can maybe re-challenge medicines which we have initially worked for the patient. And maybe systemic treatment, we have cabazitaxel as another option also. I thank Bayer for the opportunity. I'm open for questions.
Thank you, Doctor. Thank you so much for the insightful and informative presentation, sir. We truly appreciate your time and sharing your experience, sir. We have a couple of questions in the chat box, sir. 1 minute, sir. Hi, Doctor. For patients above 70 years with good ECOG performance performance status, are you comfortable offering triplet therapy, or do you individualize treatment based on fertility? Hello, Doctor.
Sorry, sir, I was speaking with the mic off. Okay, sorry.
No,
So more than 65 years of age, generally the bone marrow reserve is roughly 100 minus the age in age. That is representing the bone marrow cellularity. So beyond more than 70 years of age, the bone marrow cellularity reduces. So their tolerance to chemotherapy might be compromised. So we need to look at the other fitness, whether they're able to take care of themselves, whether they're able to climb 2 flights of stairs, whether they are on polymedications, whether they have other comorbidities. Based on this, we can decide fitness for chemotherapy. In case we find the patient to be frail and less fit, so we can initially start with the androgen deprivation therapy along with an darolutamide, and after say 4 to 6 weeks. When the patient improves, we can always reassess the fitness and consider as addition of systemic treatment at that point. Or we can even use a favorable schedules for systemic treatment like once in 2 weeks docetaxel, so that we can monitor for the tolerance also.
Thank you, sir. One more question is also there, sir.
Yes, sir.
Good evening, doctor. The RSN's analysis showed that achieving an undeductible PSA was associated with improved outcomes. In your practice, how do you use yearly PSA decline to counsel patient or assess treatment response?
Yeah, we always use a PSA monitoring only. We tend to delay imaging also because it is PSA very much correlates with the imaging response in prostate cancer. We would advise PSA initially at 4 weeks and then at 8 weeks, and then subsequently we can even do it at once in 2 months. But generally in my practice, I am not changing my practice based on the velocity, PSA velocity or the rapidity of fall. But if you find the PSA to be stuttering, if it is not falling once like earlier, then at that point we need to be more cautious and think of why we are failing, whether any compliances issue is there, or if we are treating it in full, then we'll have to be careful, and such patients may not do well in the long run.
Thank you, Mr. Doctor. And one more question right now posted. Have you encountered any challenges in initiating triplet therapy in elderly or comorbid patient, or how do you overcome them?
Yes, as we earlier discussed also, when the patient is having elderly and multiple comorbidities, we be soft on their treatment. Initially, I would start with androgen deprivation therapy. If they are not even fit for any additional medication like androgen pathway inhibitors, then I would just start androgen deprivation therapy and look at them once in 3 or 4 weeks, see how they are improving, then start adding each agent. Second, I would add androgen receptor pathway inhibitor. After 1 month of it, if the patient feels better, then I would consider systemic chemotherapy addition. I would add chemotherapy the last in such patients because the tolerance to androgen deprivation therapy and androgen receptor pathway inhibitor is better than either adding chemotherapy earlier.
Thank you, sir. Thank you. I hope there is no further question, sir. Once again, thank you everyone for your active participation and engaging discussion, and sharing some interesting question in the chat box. And we sincerely thank Dr. Karthikeyan sir once again for an excellent presentation and for addressing our questions. We hope today's session has provided valuable clinical insights that can be benefit our practice. Have a wonderful evening and stay safe. Thank you, sir. Thank you very much for.
Thank you, everyone. Good night. Good evening.
Good evening, sir. Thank you. Tech team?
Yes, sir.
Yeah.
Can we close
We
this
can
session,
end.
sir?
Yeah, we can end the session.
Okay, sir. Thank you.